This is John Deaver. He has been working at Saltzer since 2022 as the director of gastroenterology. He treats typical gut issues such as acid reflux, IBS, IBD, and other related diseases. He completed a fellowship in gastroenterology at UCSF School of Medicine in Fresno and a residency in internal medicine at Virginia Mason Medical Center in Seattle. He earned his medical degree from Saba University. While clinical faculty at UC San Diego School of Medicine, his research has been published in multiple top peer-reviewed journals. He has had the highest adenoma detection rate of 67% among his peers. All right, John, take it away.
Thank you so much for having me. I really appreciate it. Sorry I couldn't make it there due to unforeseen circumstances. I'm still here in the Boise area. Many thanks to Steve Reams and Nick Lewis for having me. This is a privilege. So this is an ambitious talk here. I'll try and get through a lot of subjects, but primarily my focus will be colon cancer screening guidelines and guidelines. March is Colon Cancer Awareness Month, so this is very apropos. Okay, so the outline for today will be talking about GERD, and I'll talk about dietary interventions for GI disorders. Yes, I'm a GI doctor who will be talking about diet and its role in health and disease. This is somewhat unusual, but it's profoundly important. So obviously I talk about colorectal cancer screening as well. In there, I'll talk about a few other disorders. And then in terms of questions, feel free to save those for the end. So for GERD, this is one of the most common diseases seen by primary care doctors, GI docs, and surgeons. Arguably, it is the most common GI disorder in the country. A unifying definition is somewhat difficult, and that's changed over the years, but based on the most recent guideline paper, the definition boils down to reflux of gastric contents into the esophagus that results in symptoms and/or complications. Complications being erosive esophagitis or a stricture in the esophagus or Barrett's. When I took the board examination for GI, the pathophysiology hallmark for acid reflux was transient lower esophageal sphincter relaxations. That has evolved to basically defining it as a poorly functioning EGJ, esophago-gastro junction, and that's the same thing as GEJ, gastroesophageal junction. So let's go back here. There we go. Not sure what happened. Typical symptoms of acid reflux: heartburn and regurgitation. These are not specific. So what are other things that can cause heartburn? Not all heartburn is acid reflux. That's really important to know. Eosinophilic esophagitis can present with heartburn. You can have other disorders that present with those symptoms: rumination, reflux, hypersensitivity, functional disease. And you'll see that come up a few times here in the presentation. What is functional? When all of our objective testing is negative, basically it boils down to a functional disorder. I'll talk about that more later. Achalasia, heart-lung conditions, hypohernia, those things can result in heartburn and regurgitation. There's no gold standard in the diagnosis of acid reflux. This is a figure taken out of a recent guideline paper for acid reflux. It is the diagnosis and management of GERD. So if you follow this algorithm, it basically makes it fairly simple. If you have a patient with heartburn and/or regurgitation without alarm symptoms, you basically want to try a PPI. Do it for 8 weeks. Ideally, take it 30 to 60 minutes before the first meal of the day. If there's relief, you likely have the diagnosis of acid reflux. And then after that, you probably want to discontinue the PPI. If you can get patients off of a PPI, that is the way to go. Most patients with acid reflux don't need to be on lifelong PPI therapy. And then if symptoms recur after you stop the PPI, you want to do an upper endoscopy. You want to uncover a different diagnosis, perhaps like EOE. So how would you plan on discontinuing the PPI and ensuring that the patient does well? Really, while they're on the PPI, you have to really hit the lifestyle modification for acid reflux hard. For them to come off the PPI and do well, again, you have to harp on the lifestyle modification. So what if they do the 8-week trial of PPI and they still have symptoms? Well, at that point, you want to do an upper endoscopy, ideally off of the PPI. So before the upper endoscopy, make sure they are not taking the PPI for at least 2 to 4 weeks. Why? That increases the yield of the diagnosis. If you do the upper endoscopy and they have inflammation, or if they have evidence of Barrett's, yeah, the diagnosis of GERD has been confirmed. What if the upper endoscopy is normal, or they have very minimal erosive esophagitis? Well, then at that point, you probably want to consider reflux monitoring. So that's a Bravo capsule. You want to assess the acid status and the symptom while they're off the PPI. And so in all of this, it's always important to acknowledge that there could be something else other than GERD that's causing these symptoms. Endoscopy is the most widely used test examination for evaluation of GERD. In the prior slide, I put up there what are alarm symptoms. If any patient has dysphagia, anemia, vomiting, bleeding, or weight loss, they should get an upper endoscopy right away. That is profoundly important. The most common finding upon doing an upper endoscopy for GERD-like symptoms, it's a normal esophageal mucosa. And again, like I said before, to maximize the yield of diagnosis, an upper endoscopy should be performed when the PPIs have been stopped. So this is the Los Angeles classification scheme for reflux esophagitis. This was initially published in I believe 1994. Basically, every GI doc relies on this to grade the severity of reflux esophagitis. LA grade A is very minimal. This is a small break in the squamocolumnar junction. LA grade B, C, and D. If someone has that on an upper endoscopy, that basically means that they in fact have acid reflux. LA grade D, that's quite severe when at least 75% of the esophageal circumference is involved. And I will show you, these are endoscopic pictures of reflux esophagitis. In the top left column, that's actually normal. That's a picture of the distal esophagus, close to where the esophagus meets the stomach. In the middle column, top picture, that's also normal. That's a good picture of the Z-line, the interface between squamous epithelium and columnar epithelium. And then in the top right, that's grade A esophagitis. There's a small break in that Z-line, and that's really minimal erosive esophagitis. Grade B, C, and D, that's in the lower row. Obviously, grade D there, you can see how severe it is. We don't see this too commonly, but in the scenario of LA grade B, C, or D, typically these patients require PPI therapy indefinitely. And I'll talk about that more in a moment. So this is also taken from that guideline paper. I'll go through this fairly quickly as we've already touched on most of it. For patients with classic GERD symptoms of heartburn and regurgitation who have no alarm symptoms, we recommend an 8-week trial of an empiric PPI once daily before mealtime. We recommend attempting to discontinue the PPIs in patients whose classic GERD symptoms respond to an 8-week empiric trial of PPIs. We recommend diagnostic endoscopy, ideally after PPIs are stopped for 2 to 4 weeks, in patients whose classic GERD symptoms do not respond adequately to an 8-week empiric trial of PPIs, or whose symptoms return when the PPIs are stopped. In patients who have chest pain without heartburn and who have had adequate evaluation to exclude heart disease, objective testing for GERD is recommended. It's always important, especially in males, as heart disease is the #1 killer of men in the country, to always consider that. If someone has certainly chest pain, but heartburn as well, consider cardiac disease. We do not recommend the use of barium swallow solely as a diagnostic test for GERD. We recommend endoscopy as the first test for evaluation of patients presenting with dysphagia or other alarm symptoms. We talked about that. And I think most GIs in the community would bend over backwards to get patients in a timely fashion. Currently, wait times are a little bit long, but I think patients with alarm symptoms certainly would necessitate quick action. And patients for whom the diagnosis of GERD is suspected but not clear, and endoscopy shows no objective evidence of GERD, we recommend reflux monitoring. We recommend against performing reflux monitoring off therapy solely as a diagnostic test for GERD in patients known to have endoscopic evidence, LA grade C or D reflux esophagitis or Barrett's esophagus. For management, we recommend weight loss in overweight and obese patients for improvement of GERD symptoms. If you were to look at all the lifestyle modification for acid reflux, what are the ones that in literature have been shown to be the most beneficial? It's weight loss, losing weight around the midsection and avoiding late evening snacks. So usually you do that, and for some patients, the reflux symptoms subside. We suggest avoiding meals within 2 to 3 hours of bedtime. We suggest avoidance of tobacco products, smoking, and patients with GERD symptoms, obviously. We suggest avoidance of trigger foods for GERD symptoms. Patients with GERD-like symptoms, they should not be given a blanket dietary recommendation to avoid citrus fruits and coffee and mint, things of that nature. It really depends on if they can identify trigger foods. If there's certain foods that lead to symptoms, certainly try and help them scale back on that if possible. We suggest elevating the head of the bed for nighttime GERD symptoms. This does not really mean just propping up the torso with pillows. Really, if you can, if they have a bed frame, simply raise the head of the bed 4 inches. You can use a block or bricks or whatever have you. That's the ideal way to actually elevate the head of the bed. We recommend treatment with PPIs over treatment with H2 blockers, especially for healing erosive esophagitis. We recommend treatment for PPIs over H2 blockers for maintenance of healing from erosive esophagitis. We recommend PPI administration 30 to 60 minutes before a meal rather than at bedtime for GERD symptom control. And for patients with GERD who do not have erosive esophagitis or Barrett's, and whose symptoms have resolved with PPI therapy, an attempt should be made to discontinue PPIs or to switch to on-demand therapy, in which PPIs are taken only when symptoms occur. For patients with GERD who require maintenance therapy with PPIs, the PPIs should be administered in the lowest dose possible that effectively controls the symptoms. We recommend against routine addition of medical therapies such as prokinetics, baclofen, and PPI non-responders. We'll talk about that more in a moment. We recommend maintenance PPI therapy indefinitely. Yes, that is forever. For patients with LA grade C and D esophagitis, some could argue even for patients with LA grade B esophagitis. Why is that? From all the studies, basically nearly everyone who has an upper endoscopy and where we see grade C or D esophagitis, the PPIs are great in healing that. But nearly everyone, if they stop the PPI in that setting where they have this history of grade C or D esophagitis, upon stopping the PPI, it returns in nearly all patients. And then, of course, that can lead to problems. It can lead to strictures and Barrett's and cancer. So that's very important to acknowledge. We do not recommend baclofen in the absence of objective evidence of GERD. This is somewhat experimental. I've used baclofen before, but generally I would stay away from baclofen and prokinetics. We do not recommend sucralfate for GERD therapy except during pregnancy. I'll talk about that more in a moment here. And we suggest on-demand or intermittent PPI therapy for heartburn symptom control in patients with non-erosive reflux disease. So medications for GERD, PPIs, they've gotten some bad press recently in the past few years, but they are in fact the most commonly prescribed medication for GERD. They provide superior heartburn and regurgitation relief compared to H2 blockers, improved healing compared to H2 blockers, and they achieve faster healing rates compared to H2 blockers. GERD symptom relief and healing rates differ little among the 7 available PPIs, so you can do whatever, pantoprazole, omeprazole, lansoprazole, etc. They basically are all the same. Dexalan does provide longer relief, but it is also more expensive. Bedtime dosing is less effective than a pre-dinner dose in acid control. It's amazing what we see in clinic, how patients are taking their PPIs, but it's all over the place. During mealtime, after mealtime, at bedtime. So it goes back to ideally the timing. The time to take PPIs is before mealtime, half an hour to an hour. Maintenance PPI therapy is recommended for complications. Definitely LA grade C and D esophagitis, and certainly Barrett's esophagitis. The lowest effective dose is the target, and you can abruptly stop the PPI. That is okay. There's some theoretical concern that if you stop it cold turkey, that patients might have a rebound in acid reflux. But that is all theoretical, and I've not seen any data to have concern over that. So you don't necessarily need to taper. You can stop it abruptly. You can take H2 blockers at bedtime, but really there's an issue with tachyphylaxis there. If patients are taking it on a regular basis, there's some concern that just the body gets used to it and it renders it ineffective. I would stay away from prokinetics. Certainly in my practice, I do not prescribe Reglan due to the black box warning. Even if they have a history of gastroparesis, I really try and stay away from that one. There are other medications that can be helpful for gastroparesis. Baclofen, I would probably stay away from that. I've prescribed it a few times, as I mentioned before. Sucralfate, this is a mucosal protective agent. Really, its efficacy is similar to H2 blockers. But in terms of all medications available, I would go with PPIs, certainly above sucralfate and H2 blockers. Treatment of GERD in pregnancy. So this is something that happens quite frequently. Approximately 2/3 of pregnant women experience heartburn. Treatment of GERD during pregnancy should start with lifestyle, certainly. We touched on that before. Really preach the lifestyle measures to control acid reflux. If this fails, you can try antacids, alginates like Gaviscon Advance, and sucralfate. Those are considered first-line therapeutic agents. Sucralfate was superior to dietary and lifestyle modifications for relieving heartburn and regurgitation in pregnant women in a small randomized control trial. So certainly in pregnant women, go with sucralfate. H2 blockers are category B. PPIs are the same except for omeprazole, which is category C. You can still use those, but I would really go with sucralfate. So refractory GERD, up to 40% of patients treated with PPIs will report persistent symptoms of heartburn and regurgitation with negative effects on quality of life. So what do you do at that point? This is quite common. So the first step, that goes back to optimizing PPI therapy. The timing is critical, and ideally, if they take it before breakfast or before the first meal of the day, that should provide the most benefit. However, some patients have more symptoms at night, and PPIs don't last 24 hours for the most part. Their duration of action is roughly 11-12 hours. So if patients need to take it twice a day, take it before the first meal of the day, and then also take it before dinner. Perform upper endoscopy off PPI therapy. In the case of refractory GERD-like symptoms, even if the esophageal mucosa looks normal, guidelines specify that we should be taking biopsies because eosinophilic esophagitis which is a somewhat new entity, initially diagnosed in the 1990s, but we're seeing just more of it. And we can actually uncover esophageal eosinophilia with the biopsies. So even though the esophageal mucosa might look normal, you still biopsy it to uncover conditions like EOE. You can consider esophageal pH monitoring, and we can also consider esophageal manometry to see if there's a dysmotility disorder. Possible mechanisms behind refractory GERD. Despite PPI therapy, abnormal acid reflux could persist. This is somewhat unusual, but in conditions like Zollinger-Ellison syndrome, where there's hyperacid secretion, yes, certainly this can happen. You can have reflux hypersensitivity. That's a condition in which PPIs have normalized esophageal acid exposure, but you have these physiologic reflux episodes that lead to symptoms. Symptoms are not due to GERD, but are caused by esophageal disorders, EOE, achalasia, etc. Symptoms are not due to GERD, but are caused by non-esophageal disorders, such as gastroparesis, rumination, or heart disease. In the setting of gastroparesis, if the stomach is not emptying appropriately and contents remain in the stomach, well, there's just a greater chance for reflux events. So consider that as certainly as someone who has refractory GERD-like symptoms. Symptoms are functional. That's not because of GERD or any other identifiable disorder. That basically we see functional when our biopsies are normal, when motility studies are normal, and there's no structural abnormality. Treatment options for refractory GERD, you could do anti-reflux surgery. Make sure you go with an experienced surgeon. You could consider magnetic sphincter augmentations. This is the LINX system. This is really, in my mind, a new the device and treatment. And this is stated in the guideline paper, but I really wouldn't go with it due to how new it is and given the rates of dysphagia. So you could potentially consider it, but with newer modalities and treatment, I try and stay away from that until it has been well established. For the patient with GERD symptoms who is obese and who are candidates for a route like gastric bypass, you could consider that, certainly. So long-term PPI issues. So this has gotten a lot of press recently, especially in the last 5-10 years. But regardless, PPIs are the most effective medical treatment for GERD. And then in these studies that really have become sensational, and they've been in the news, and they've made a lot of people concerned, and we should be concerned. If there is adverse events associated with PPIs, we should really know about it. But based on all the studies, there's an association between long-term PPI use and the development of adverse conditions. And this ranges from intestinal infections to pneumonia, to cancer, to vitamin deficiencies, cardiac disease, strokes, dementia, etc. Really, none of these studies have established a cause and effect relationship. And from numerous studies, really the only thing that PPIs are predisposed to is a slight, marginal increase in intestinal infections. So if someone's taking a PPI and the pH increases and that first-line defense against ingestion of bacteria is diminished, yeah, of course, they can be predisposed to intestinal infections, but this is a marginal increase in risk. Patients with GERD on PPIs who have no other risk factors for vitamin B12 deficiency, they don't need to raise their intake of B12 or undergo routine monitoring. If I see a patient in clinic and they've been on PPIs for a few years, I'll do like a one-time check of a B12 level to see if there's any deficiency there. So you definitely need acid. You need to ingest vitamin B12. You need acid to metabolize it. You need a pancreas and a small bowel to absorb it. So, certainly if someone's been on a PPI for a long time and they're seeing me, I usually try and go the extra mile and do a one-time check, but no routine monitoring is necessary. Patients with GERD on PPIs who have no other risk factors for kidney disease do not require routine monitoring of the creatinine level, but again, patients generally get routine labs, including a creatinine level. If a patient does have renal insufficiency, I would pursue close monitoring. From epidemiology studies, patients on a PPI, there has been this link to worsening renal function, so keep that in mind. Now moving on to a different section, dietary interventions for select GI disorders. This is profoundly important, and for almost all of my patients that I see in clinic, I really try and harp on dietary changes. Really, if I can convey to patients the importance of dietary interventions, being on the right diet, and exercise, and sleeping well at night, and I throw in there the importance of keeping your relationships in good order, that is a lot more than what I can do in terms of prescribing a PPI or doing a procedure. Really, for increasing health span, we need to focus more on these lifestyle changes. According to a recent survey, GI fellows believe their knowledge of nutrition, including modified diets, is suboptimal. This is across the board. In GI fellowship, there's not a lot of emphasis on knowing the value of nutrition, and really the literature kind of backing up its importance. We learn how to do procedures, but a little emphasis on preaching dietary changes. The diet-related diseases, I think historically we think of systemic hypertension, we think of cardiovascular disease, stroke. But really, this diet plays a profound role in GI disorders. Everything from fatty liver to diverticulitis to pancreatic disease to celiac disease. Very, very important. Along with that, diet plays a role in obesity, and we're currently in an epidemic here. 40% of the population has elevated BMI. And according to the U.S. Burden of Disease Collaborators, in 2016, there were 500,000 deaths associated with dietary factors, making them the leading risk factor for mortality. About a third of the most common neoplasms could be avoided by changing lifestyle and dietary habits in developed countries. And so because of this and other reasons, I really harp on this to my patients. And changing lifestyle is so difficult. I really put myself in the position of patients. But it's something that requires multiple providers being on the same page and preaching the right thing. It's much easier to take a medication, a pill, than to change lifestyle. But the conversation has to continue, and we should bring this up to most, if not all, of our patients. General dietary recommendations. So Kaiser Permanente, one of the largest healthcare organizations in the country, they endorse plant-based diets. They're both cost-effective, low-risk interventions that may lower BMI, blood pressure, hemoglobin A1C levels, and cholesterol levels. And according to their statements, physicians should consider recommending a plant-based diet to all of their patients. When I bring up a plant-based diet, most of my patients, they right away look at me in fear and disappointment. And I think many patients, when they hear plant-based diet, they think of a vegan diet and no meat at all, and to give up their pleasure foods. But really, that's not the case. It's really, I think, moderation and avoiding processed foods and limiting animal products. But basically, it's defined as unrefined plant foods such as vegetables, whole grains, consuming nuts, seeds, legumes, fruits, with few or no animal products. In there, they had mentioned seeds and nuts. This should, I believe, be one of our primary sources of protein. Nut consumption is inversely associated with total and cause-specific mortality. This is data that came out from a New England Journal of Medicine article. It was a 30-year follow-up study. Yes, doing studies related to diet are somewhat difficult, but this was This was very eye-opening. Consuming nuts more than 7 times a week had a lower, 20% lower death rate. So, and consuming nuts, yes, it is okay in diverticulosis and patients with a history of diverticulitis. That myth was really disproven more than 10 years ago. So, a lot of patients believe that with their history of diverticulitis, they cannot consume any nuts and seeds. That's not the case. Mediterranean diet. Mediterranean diet reduced recurrent cardiovascular events by 72%. That's profound. This is from the Lion Heart Study. The Mediterranean diet mainly consists of cereals, grains, vegetables, beans, fruits, and nuts, along with moderate amounts of fish and cheese, olive oil, and wine. Lifestyle intervention, diet and exercise was more effective than metformin for reducing incidence of type 2 diabetes. And diabetes is linked to so many other things. It's associated, it is a form of metabolic disease. I'm seeing more fatty liver disease in the clinic. So again, lifestyle intervention is profoundly important. Avoiding ultra-processed foods. Really, the first step in changing diet, it might start with this. The definition, basically, it's food that's undergone multiple physical, biological, and/or chemical processes. It's deemed to be safe. It's certainly convenient, palatable, and affordable. But if you can get patients to change this habit, I think that's the initial first best step. It's associated with a high risk of dyslipidemia, obesity, hypertension, mortality, and cancer. In one study published in the BMJ journal, British Medical Journal, ultra-processed foods were associated with higher risks of cancer. Basically, a 10% higher intake of ultra-processed foods had a greater than 10% increased risk of cancers. So this is from the U.S. Department of Health and Human Services. Basically, it's all inclusive. They really don't rule anything out. They do recommend, yes, a variety of vegetables from all subgroups, dark green veggies, red and orange, legumes as well, fruits. They do mention fat-free or low-fat dairy products, including milk and yogurt. Based on my little research recently, and talking to scientists, especially scientists who focus on the microbiome, I really would steer patients away from consuming dairy products, especially in adulthood, because they're inflammatory. As it stands, up to 60% of the population in the U.S. is lactose intolerant. So I really try and have them stay away from that. And legumes are profoundly important. They are a superfood. And that mostly consists of beans and peas. Peanuts are technically a legume. So that's what I preach to my patients. Diet and longevity, it's amazing, but genetics only determines about 20% of longevity. We commonly see patients in clinic or who are coming in for a procedure and they're 80 or older and they seem to be doing really well. And almost everyone says, oh, they must have good genes. Well, that's really not the case. It's their lifestyle. It's how they live their life that kind of led to increasing their health span and longevity. Certainly, it helps to win the genetic lottery jackpot, but really, for us to achieve a long health span and to hit those older years, I think it boils down to our lifestyle habits. So eating in moderation, having a purposeful life. So I think keeping your relationships in good order. That's also important. Exercise, very important. People who tend to have a faith, who are religious, have a spirituality. I think that pans out for increasing health span. Certainly avoiding obesity. That's important. I like these other factors that are mentioned in this table, such as naps. I think for the cultures that employ a siesta, they seem to be doing quite well with longevity. So that's very important to acknowledge and to discuss with patients, because a lot of them are under the impression that they needed good genes. They need good genes to live a long, healthy, productive life, and that's certainly not the case. A quick word on IBS. This is a chronic functional bowel disorder. It occurs in up to 15% of the population in the US. This really has an impact on quality of life. Patients would give up 10 to 15 years of life expectancy for a cure. So I know a lot of providers who don't want to deal with this, but this is a real entity. Our objective testing often is negative, and this is a classic functional bowel disorder, but this is real. This is a brain-gut pathophysiology disease, and we can help patients here. The direct costs associated with IBS, it's in the billions, and up to 2/3 of patients with IBS attribute symptoms to food. So we'll talk about the food remedies for IBS here in a moment. The microbiome, it's profoundly important in a lot of things. Cardiovascular disease, GI disorders, IBS, diet, along with many other things, alters the microbiome. And I think finding the diet that pans out the best for IBS patients, that's really important. Generally, I think if you talk to most GI docs or scientists, you ask them in one word, what does it mean to have a healthy gut? I think in one word, I probably would say diversity of the microbiome. And how do you get that? Usually it's consuming different types of foods, having a wide variety of foods that you consume. Keep that in mind. Most of our approach with IBS treatment is dietary elimination, but I think that might swing in the opposite direction here in a few years. Fiber in IBS. Increasing dietary fiber intake is a traditional first-line treatment. Definitely go with soluble versus insoluble fiber. Soluble fibers such as psyllium husk is beneficial in the management of IBS. Numerous studies have shown this. I mentioned one here, published in the Red Journal in 2014. The proposed mechanisms of why this is, why this tends to improve global symptoms in IBS. It could be because of increased stool bulk. Soluble fiber in general is the ultimate prebiotic, so it changes the microbiome. And there are probably effects related to the neuroendocrine system of the GI tract. FODMAPs. FODMAPs are short-chain carbohydrates. Really, in past years, the first step in the management of IBS comes with dietary elimination, doing the low FODMAP diet. High FODMAP foods tend to trigger symptoms. So our initial steps are typically to try the low FODMAP diet, and that's not a be-all end-all diet. You just try that for 2 to 4 weeks. If they respond to it, and most patients, more than half, do respond to the low FODMAP diet. At that point, you start reintroducing foods, one food group at a time, 1 week at a time. And by that, you determine sensitivities and you come up with your own personalized diet. I mentioned a study here that the low FODMAP diet does in fact work. Most patients with IBS experience relief. What about gluten? I have a lot of patients who come to clinic and they're on a gluten-free diet, and I think there's some literature to back this up. Gluten is a complex protein found in wheat, barley, and rye. Based on some studies, it does lead to gastrointestinal symptoms. It is difficult to digest, even in patients without celiac disease. So there's a study here kind of mentioning that. However, with further studies, it doesn't seem like gluten is the culprit in the majority of cases. Patients have abdominal symptoms. In fact, it is not gluten. I'll talk about some of the studies here in a moment. So this is a table taken from a study published in the Red Journal, the American Journal of Gastroenterology. And you have a lot of different dietary approaches for managing IBS. You have the lactose restriction, gluten restriction, the low FODMAP, the spicy foods restriction, etc. But really, the low FODMAP diet, I just wanted to point out that this is not a one-size-fits-all approach. It's a restrictive diet. And so you got to be careful, and you don't want patients on this long term. This is not a long-term dietary recommendation. Certainly, you don't want to avoid the low FODMAP diet in a young person with IBS with a history of an eating disorder. You don't want to further limit or restrict their diet, thereby potentially leading to micronutrient deficiencies. So keep that in mind. Celiac disease, this is a patchy disease that affects the small bowel. The treatment is a strict lifelong gluten-free diet. A lot of patients with celiac, they wonder how much is too much. Like they love their carbs and they try and think to themselves, okay, what can I get away with? But generally, scientists believe that roughly 10 milligrams of gluten is less than that is probably safe. Once you get to about 10 milligrams or more, that will likely lead to intestinal inflammation. And so what is 10 milligrams of gluten? That's minuscule. It's roughly a teaspoon of crumbs of wheat bread. So really, they have to avoid that. Labeling by the FDA, that really boils down to less than 20 parts per million. And then, do you have to avoid oats in celiac disease? No. There's similar genetic makeup, homology between oats and wheat, but oats are okay. Oats do not contain gluten. There could be cross-contamination, but generally speaking, oats should not contain gluten. For patients with celiac disease, refer to a dietitian. That's really important because a lot of patients with celiac, they get this inadvertent gluten intake, which leads to symptoms. Medications and supplements, there's poor FDA oversight with supplements. And as we know with medications, besides carcinogenic materials, they could contain gluten. So keep that in mind. They might need to sit down with the pharmacist to review their medications. There's non-celiac gluten sensitivity. Now, what is this? It's in individuals without celiac disease, but who have symptoms related to ingestion of gluten. And really, the symptoms alone cannot reliably differentiate between the two, celiac and non-celiac gluten sensitivity. Really, the mechanisms are unclear, but from further studies, it's really shown that gluten is not the culprit. I'll mention the study here in a moment. So celiac occurs in 1% of the population. This global phenomenon of self-reported wheat sensitivity, it's really crazy. So 10% of the population report a wheat sensitivity. And so a lot of people believe that it was all about the gluten. And there's one study here in the American Journal of Gastroenterology. They went so far as to say that it's really that protein gluten that's triggering symptoms. But there was a follow-up study, and they really determined that it's not gluten. Really, fruit cans are the cause of symptoms in patients with this self-reported wheat sensitivity. There was a study, and this is a little table from the study, but it was well conducted. They had 3 bars, and they looked identical. One bar was the fruit can bar. There's a gluten bar, only consisting of gluten, and then there's the placebo bar, not consisting of either. And so basically, these patients who had self-reported this gluten sensitivity, they in fact did not have the sensitivity to gluten. They had the sensitivity to fruit cans. So the fruit can, if you look at wheat, it's made up of fruit cans, which are a polymer of fructose and gluten. So most of these patients with this self-reported gluten sensitivity don't in fact have a gluten sensitivity. They have a fruit can sensitivity, and the low FODMAP diet might be better for them. EOE, this is a new disorder. Like I mentioned, initially diagnosed, discovered in the 1990s. PPI response should not be used in the diagnosis. And in terms of treatment, we have topical steroids, PPI therapy, and diet. I would really, in my practice, I go with PPI therapy and diet. Now, what are the dietary approaches to treating this? There's the 6-food elimination diet, but really I wouldn't wish this upon my worst enemy. Sometimes you have to do this, but really what I start with is avoiding dairy and wheat. Dairy and wheat tend to be the most allergenic in UE. So keep that in mind. I would stay away from the elemental diet. This is the cover of the Journal of Gastroenterology in 2012 landmark study. It really highlights what the 6-food elimination diet does, just by avoiding certain things in the diet that actually achieved histologic remission and improvement in symptoms. So you have the first column, the pre-diet. You can see the changes there, the long lines, the rings, a lot more pronounced than the middle column, which is the endoscopy after imposing the 6-food elimination diet. And then the reintroduction and that column to the right, you can see how all of those features kind of return, the long lines, the longitudinal furrows, the rings. So diet plays a profound role in the treatment of EOE. Okay, so let food be thy medicine and medicine be thy food. Hippocrates was onto something way back when. The potential for dietary changes or treatment, it far outweighs the proof. Conducting dietary studies not easy to do. But please emphasize good nutrition. That is good medicine. Plant-based diets, avoid processed foods, and try to eat to 80% full. Now moving on to colorectal cancer screening. It's one of the most common cancers in the United States. Screening options involve both invasive and non-invasive tests. Really, what's the best screening test? It's a balance between performance and cost. For me as a gastroenterologist, hands down, colonoscopy. How does Cologuard fit into your approach? And then how early to screen? Now it's 45. Everyone should know that. However, I performed a colonoscopy on a 50-year-old lady yesterday, and she had a circumferential mass in the ascending colon, and she didn't have any symptoms. And so we see this too commonly, and it's so sad. A 50-year-old lady who's following prior guidelines shows up, she does her due diligence, she's coming in for a colonoscopy, and here we have a diagnosis of colon cancer. She's got six kids, 2 of them are in college, but this is so unfortunate because we can get more patients screened, patients who are younger than 50. And then how does family history work into your approach? We'll talk about that in a moment. It is the 3rd most common cancer in men and women worldwide. There's roughly 150 new cases of colon cancer each year in the US. About 50,000 people will die from colon cancer yearly. Lifetime risk is between 4 and 5%. It is the 2nd leading cause of cancer-related death among women and men combined. 90% of cases occur in patients 50 years of age or older. What does this make you think of? What's going on with the other 10%? The 10% are typically diagnosed before 50 years of age. And then rectal cancer, usually distal cancers occur in younger patients. And then as patients get older, certainly older than 60, 65, we see the colon cancer arise in the right colon, in the cecum, and the ascending colon. Colorectal cancer incidence and mortality have been decreasing in the past 2 decades due to screening and early detection. This is a good thing. Colonoscopy saves lives. There's been a 32% reduction in incidence of colorectal cancer in individuals greater than 50 years of age. And then colorectal cancer mortality declined by 34% in those years. So that's great. However, where are we falling short? Nearly 1/3 of eligible US adults have never been screened. That's a problem. Mortality increased in individuals younger than age 50. And so we had this data from between 2000 and 2014. New cases of colon cancer went up 20% in people younger than age 50. And really, I credit the American Cancer Society. They were the first professional society to update the guidelines. They did that in 2018. My hat goes off to them. They really uncovered this and pushed forward. And then fast forward to 2021, the United States Preventative Services Task Force adopted it. So really now everyone who's average risk should get screened at age 45. Colorectal cancer incidence and mortality remain higher in Blacks. So even if you, in the African Americans, Blacks, even if you correct for access to care, socioeconomic status, they do run a higher risk. So keep that in mind. Perhaps maybe in years to come, we might lower the screening age for Blacks to 40, but that remains to be seen. This is a table reproduced from the American Cancer Society, and I've outlined the colorectal cancer approach for screening. So there's the opportunistic screening and there's programmatic screening. Usually for most of us, we come across the opportunistic. It's basically results from an office-based interaction between the provider and the patient. My approach really, when I see patients, I go with the risk stratified approach. I offer the colonoscopy. And here in this table, it says that this should be certainly offered for patients who are predicted to have a high prevalence of advanced precancerous lesions. Well, the question I would throw out there, how common are precancerous lesions in the colon? So with the introduction, there's a mention of adenoma detection rate. If we're finding precancerous lesions and people, and 67% of people who are 45 years of age and older, well, basically, in my mind, everyone should be getting colonoscopy because those are technically ticking time bombs. So keep that in mind. But really, what to do for the screening test? It's the one that gets done. Really, if the patient has concerns over colonoscopy, that's okay. But do something, offer something, and just ensure that they get screened. This is from the Multi-Society Task Force. There's Tier 1, Tier 2, and Tier 3. Really, the only two tests that occupy Tier 1 in terms of screening tests, it's the colonoscopy and the FIT. The colonoscopy advantages its high sensitivity for colorectal cancer in all classes of precancerous lesions. It's both diagnostic and therapeutic. And then we've shown a reduction in incidence and mortality significantly. Disadvantages, yeah, the bowel prep is not fun. You could perforate, however, if you go to an experienced endoscopist, that risk is negligible. You could have aspiration pneumonitis or other problems, but if you're in good hands, I think there should be very little worry about the negative outcomes. What about the FIT? This is non-invasive. It has a one-time sensitivity for cancer of 79%, and it's cheap. It is only $20. Disadvantage is you have to do repeat testing, ordinal sensitivity of serrated class precursor lesions. What is that? So if we talk about precancerous colon polyps, that boils down to tubular adenomas and cystosserrated adenomas. Tubular adenomas tend to be hemorrhagic. They leach blood, and the FIT will pick up on this. However, the serrated class lesions, they tend to be non-hemorrhagic, not until they're very large. So keep that in mind. The Cologuard, this was approved in 2014. CMS approved the test for reimbursement and recommends performance at 3-year intervals. It's pretty good. It has a one-time sensitivity for colorectal cancer at 92% versus FIT 74%. So that's something you can consider. However, it is expensive compared to the FIT. We're talking about a cost of $600 versus the FIT, which is $20. And you do run the issue with more false positive results. This is a table comparing the different colorectal cancer screening strategies. So I would definitely go with colonoscopy. In terms of family history, if there's colorectal cancer or an advanced adenoma, if 2 first-degree relatives diagnosed at any age, basically it should be a colonoscopy every 5 years, beginning 10 years before the age at diagnosis of the youngest, or at age 40, whichever is earlier. If you have colorectal cancer or an advanced adenoma in a single first-degree relative diagnosed after age 60, basically begin at 40 years of age. And then if the colonoscopy is normal, you can revert to average risk screening recommendations. So conclusion, The best colorectal cancer screening test is the one that gets done, hands down. If patients defer the colonoscopy, there are other good choices. Colonoscopy and FIT are in fact the top choices. 1 in 3 people are not up to date with colorectal cancer screening. Average risk patients should begin screening at 45 years of age and consider early screening. That is my talk. Thank you so much for bearing with me.
Okay, we have a couple minutes for questions, and our winner is Stan Moss. Yay, congrats. Any questions?
With the popularity of like Traeger grills and smoking and barbecuing, could you speak to that topic as patients ask questions about that type of cooking?
Yeah, good point. If you look at certain countries like Chile and Japan, they do a lot to preserve their foods. So there's a lot of smoked foods and salted foods. In those countries, there's a higher risk of gastric cancer, and that's why they have screening for that. Yeah, usually any byproduct of combustion is carcinogenic. So I love barbecue myself. There's moderation. I try and preach moderation. If you do a lot of barbecuing, that's carcinogenic material there. So just keep that in mind. Just try and limit it if you can. Red meat is in fact a risk factor for colon cancer. So I mentioned that to patients. Last year for Colon Cancer Awareness Month, I met up with the GI folks at Intermountain, and it was the table had like 30 people, and we went to a steak joint for dinner, and I thought it was a little bit funny. Yeah, I mean, I think it's ingrained in our culture, and I have an appetite, for meat at times, but I'm mostly plant-based. But yeah, it's if you can avoid that, grilling foods and staying away from red meat, that would be wise.
You want me to have both? Okay. Hi there. Thank you so much for your talk. That was excellent. Ann Huntington, internal medicine doc. You spoke about fructans or fructans. What foods would tend to have less of those? It looks like maybe spelt and certain grains would have less than wheat to be able to still have some grains, but on a lower fructan diet. And then oftentimes when folks will go to Europe for 10, 14 plus days, their GI symptoms will feel much better on the diet there than when they come back. Sometimes those symptoms come back. So the gluten in many of the breads now the gluten content is much higher, and I would assume the fructan content is much higher in the breads. So it's maybe how we're producing them in a fermentation process, et cetera. Thanks.
Yeah, thank you so much for the question. With fructans, certainly fruits. Apples tend to be a trigger for symptoms, especially in IBS patients. So for my patients with IBS or functional bowel disorders, I have them sit down with a dietitian to really comb through the diet. In terms of food quality, I think there's a big difference between the United States and Europe. If you really look at what they've banned, the red dyes, their processes when it comes to food. I mean, this is a new topic for me. In training, you really don't come across that, but slowly you learn that there is a difference in how the countries approach what they offer in terms of foods. 80% of what we find in the grocery store is processed. And I've heard the same thing. People travel to Europe and they have all the pasta and they do great. Well, I would say, yeah, part of that is the makeup of the food. I'm confident of that. However, when it comes to eating food, it's not just exactly what you're eating, but it's when, it's how, in what setting. Are you stressed? So I think when people are on vacation, I think just given how kind of relieved they are, I think that pans out in one way or form, and how they process food. So and I hear that from patients in clinic, like they can have one type of food one day. They can have one food one day and then the same food another day, and then it just triggers symptoms. So that probably comes back to the brain-gut axis and how stress changes our physiology and our microbiome. But very good questions.
It's Mike Fouts. I'm a family doctor. What do you recommend for patients during that 2 to 4 weeks when they're off their PPI prior to EGD?
Yeah, a great question. Because a lot of patients, they don't want to stop their PPI. Their symptoms are so significant. They really they really they look at me when I offer that. I say, can you stop your PPI, because that's going to really improve what we see, improve our diagnostic yield on the upper endoscopy. So in place of the PPI, yeah, they can do Tums. They can do allogeneic therapy, so they can do Gaviscon Advance. I would really try and stay away from the PPIs and the H2 blockers.
Hi, thank you very much for your talk. It's excellent. This is Amy Baruch. I'm an ER doc, but I also practice integrative medicine. So I wanted to first thank you for acknowledging more integrative approaches, because I get so much resistance, or have in the past, from GI physicians. So I'm really happy to see this shift take place. My question specifically relates to gastric cancer, and I'm seeing an increased incidence, particularly in young people. And I'm gathering it's lifestyle-based: alcohol, barbecued foods, smoked foods, other bad habits that promote cancer. But is there anything beyond that, or are you seeing an increased incidence of gastric cancer on your end?
Yeah, I haven't seen that a whole lot. I mean, I diagnose colon cancer on a regular basis. Gastric cancer, not so much. I've only had a few cases of that in the past 6 months. But yeah, I think lifestyle plays a role. I think ultra processed foods, I mean, it's just junk food, and I think coupled with the fact that people are stressed out, they're living paycheck to paycheck, and yeah, they're doing supplements that are poorly controlled. Maybe the supplements have carcinogenic material. But H. pylori, I mean, H. pylori in this country, roughly 30% of people are infected with H. pylori, and according to the World Health Organization, that is a group 1 carcinogen. So that plays a role as well. Usually based on the chorea cascade of being infected with H. pylori, acute gastritis, chronic gastritis, intestinal metaplasia, and thereby dysplasia and cancer, that usually unfolds over decades. So I think it goes back to lifestyle. I think we dramatically have to change our approach. We really have to harp on the lifestyle measures that will pan out for patients for the better.
Thank you. There's one last question online, which is, at what age do you stop colorectal cancer screening?
Oh, great question. So typically, so based on professional society guidelines, we start at age 45 and stop at 75. However, it's really difficult to predict how long someone will live. Certainly, if someone has a history of a precancerous colon polyp, I'll continue surveillance beyond 75. I'll stop when I believe the risks outweigh the benefits. So, as physicians, providers, we're not very good at prognosticating and determining longevity. So I usually continue surveillance. For screening, I'll offer that up until age 85. So if you look at the United States Preventative Services Task Force recommendations, if someone hasn't been screened before, or if they have, it's been over 10 years, you could actually repeat the colon cancer screening up until age 85. Yeah.
What do you recommend for non-inflammatory dairy alternatives?
Non-inflammatory dairy alternatives. Well, I tried myself stick with water, tea, and coffee, black coffee. But yeah, now there are all these nut milks, cashew milk, almond milk. You can go to the grocery store now and find like a dozen different varieties of nut-based milks. You can do soy milk. Really, I think we should be farmers in and of ourselves. I think we should try and make our own dairy milk substitutes at home. We should take almonds or cashews and do it ourselves. I think in years to come, we'll probably see more of that. More people will have greenhouses in their backyards, and they will be growing more and more of their own food.
Okay, last question.
With the concern about bicarb and rebound gastric reflux, what are your thoughts about Z-Grid that for 30 days that is being recommended for severe esophageal gastritis for 30 days?
Yeah, to be honest, I don't know much about that. With erosive esophagitis, PPIs are the way to go, and if they have LA grades C or D, certainly a definite treatment of that. So I stick with the medications that have a long track record and that have been shown to be safe.
Okay, thank you so much.
Thank you so much, everybody.
Okay.